Hello, everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's a real pleasure to be with you today, this afternoon, for our plenary panel discussion, State Cost Growth Benchmarking Programs, New Strategies to Drive Market Transparency and Accountability. This time, I would like to introduce our organizer and moderator, Kevin McAvey from Manat. Kevin is also our NADO Board Vice Chair. Kevin?
Good afternoon, everyone. It's so great to see so many of you. My name is Kevin McAvey. It's been a pleasure to get to work with so many of you. And today we're here to talk about state cost growth benchmarking programs, new strategies to drive market transparency and accountability. And we have some terrific panelists on with us today. Charles, if you wouldn't mind bringing the deck up, I'm going to be moving through a lot of material really quickly. So that way we could get to a couple of experts that we have today. Again, for those of you who don't know me, my name is Kevin McAvey. I've been working with healthcare claims, encounter data, clinical data, ADT data for a long time now, states, foundations, HIE, state health data organizations, helping them to develop their data strategies and build health data capacity, as well as like analyze data, translating data into information that could be used to advance policy and program goals. I want to start, like so much of data work can be very heady, and data can be an abstract concept. I want to just start with a story from the field that could ground us into why what our panelists are doing today is so important. Our healthcare system is not working as we want it to. If we do not fix it, we are destined for broader and potentially suboptimal system change being imposed upon us. We cannot fix a system we do not understand, and to understand a system, we require information about its performance, how it is delivering services for those who pay for it, and to what effect. And we have a good amount of data, and states, as we'll talk about today, are continuing to build more data resources, but we're still learning how to fully harness it. Some of our presenters today will share some best practices. I want to focus on this first point, though, again, to really underline the importance of understanding our healthcare markets. Over the last 2 decades, national healthcare spending has nearly tripled, growing faster than national income to comprise almost 1 out of every $5 of our country's GDP. And it's only expected to grow, continuing to crowd out other really important business investments that can be made, consumer purchasing for housing and food, other determinants of health, as again, the healthcare coverage costs grow. And our return on investment isn't there. Despite spending twice as much on health, the US has lower life expectancies than comparable nations, and the gap only continued to worsen through COVID-19. And so this is something that we come back to again and again. We do not all interact with the same healthcare system. Cost-related barriers to care, for example, vary widely by race and ethnicity. And again, when we think about data, we think there's so much going on, particularly right now in the landscape. I put this up just to give you a little bit of nausea and just to remind you, do not get distracted. As the policymakers on this call did today, start with identifying what information you need for your policy, regulatory, and business decision making, and think strategically about how you can leverage existing data resources or whether you need to build new ones. There's a lot going on in the market. Today, we're going to focus on cost growth benchmarking data. With this program, cost growth benchmarking data helps to frame healthcare system spending to start deeper discussions where many of these other data resources can be useful. Cost growth benchmarking programs. State policymakers are increasingly pursuing cost growth benchmarking programs in lieu of more prescriptive policy fixes, seeking to understand the problems before pursuing more prescriptive policy solutions. Approximately 10 or 11 states now have cost growth benchmarking programs in place. I note that Nevada probably took a step back in the past year, but Utah also took a step forward. These programs are set to cover over 70 million people, or 1 in 5 Americans. And healthcare cost growth benchmarking programs are data-driven initiatives that provide states with a baseline and understanding of their healthcare costs and cost growth in relation to established targets. These programs start with the consensus that healthcare spending cannot keep growing at its current rates, that we need to work together to constrain healthcare cost growth. And to do that, we need to set a target and develop a structure and a process for robust healthcare data collection. Again, these can help us understand where costs are in our healthcare system across lines of business, across our states, their impact on coverage and affordability. They help us understand the adoption of alternative payment methodologies and how many dollars are actually going to our service spending priorities, like primary care and behavioral health. I love this visual here, and I know I'm going quickly, so thank you for bearing with me, but I love this visual. What really shows we are collecting healthcare spending data in our states right now, but often it is fragmented, collecting by different measures, going to different departments. What state cost growth benchmarking programs do and do so well is bring together a comprehensive and cohesive view of market membership and cost information, a consolidated view of where our healthcare dollars are going. State cost growth benchmarking programs collect aggregate spending data from public and private payers over time to help us understand cost centers, cost drivers. They may be supplemented or piggybacked with additional requests that provide context for the populations that we're serving and their needs, as well as other information such as premiums and cost sharing that relates directly to affordability. This is spending measurement and cost growth targets are just 2 components of 6 that we have outlined here that helps us to establish a cost growth benchmarking program. And one thing that states have pursued is not only through the power of transparency and attribution to cost spending, but thinking about how we can hold our healthcare system accountable for continued cost growth. The states are determine entities that might be subject to a benchmark, targets to which those entities might be accountable, and thresholds for enforcement. Those thresholds and mechanisms for accountability can vary significantly state to state. On one side of the spectrum, even the transparency in the public reporting process for how costs are growing to a provider attributable patient population over time, holding payers and providers accountable to a particular target, whether it's 3.1 or 3.6%, making sure per member per month spending stays below that is a novel concept that we have never had in our healthcare system before. And then other states have built on just that transparency. Massachusetts, Oregon introduced small penalties. California is setting the bar for what could potentially be enforced. The last point I'll close up on here is healthcare cost growth benchmarking programs also provide states a forum and an occasion to engage the public and private industry stakeholders in a conversation around healthcare cost growth and other system issues and reform priorities. We've done a lot of work in this area. I'll throw the link in the chat. Peterson Milbank Program for Sustainable Healthcare Costs. I couldn't do a presentation like this without mentioning them as a terrific resource for many states out there who are looking to potentially start a program like this, along with our partners, Baylor Health. But with that, I'd love to introduce our 3 phenomenal speakers today. Elizabeth Mitchell is president and CEO of the Purchaser Business Group on Health. PBGH is a nonprofit coalition representing 40 private employers and public entities across the U.S. that collectively spend $350 billion annually purchasing healthcare services for more than 21 million Americans and their families. Healthcare spending and quality are paramount on their agenda. Vishal Pagani, thank you for joining us, is the inaugural Deputy Director at the California Office of Healthcare Affordability, housed within the Department of Healthcare Access and Information. Before he was named Deputy Director, Pagani was an Assistant Director was an assistant secretary at Cal HHS, where he represented the agency in policy development and negotiations for OCA. He has been in since the beginning. While Elizabeth was a key stakeholder in helping to shape what the program looked like, Vishal helped bring it to fruition and now leads it and is going to talk about their approach to program design. And last, but certainly not least, Lauren Peters, Executive Director of the Massachusetts Center for Health Information Analysis, Massachusetts independent state agency of record for healthcare information. CHIA, as it's known, serves as the Commonwealth's primary hub for healthcare data and analytics and is charged with reporting information about the quality, affordability, utilization, access, and outcomes of the Massachusetts healthcare system. Prior to CHIA, Lauren served as the Undersecretary for Health Policy at the Executive Office of Health and Human Services, and she will talk about how CHIA's cost growth benchmarking program has continued to mature. So with that, I would actually love to pass it off to Elizabeth Mitchell to start us off for as a catalyst for such reforms.
Thank you, Kevin, and glad to be here. As you noted, I am actually now on the board of the Office of Healthcare Affordability in California, and we opted to participate and contribute to the passage of the legislation because, frankly, the industry has failed to self-regulate. And frankly, these state efforts exist because the industry has chosen to not be cost-effective, reduce costs, and essentially achieve affordability. As you probably know, as everyone knows, the problem is only getting worse. And what we have to do collectively is sort of get past our Stockholm syndrome of just worrying about, the cost inputs and how hard it is for the industry to change, and really think about affordability from the consumer and purchaser perspective. That is what we have completely failed to achieve. And that is what our members are focused on, both on behalf of their sort of businesses, but mostly for their workforce, because every dollar we are putting into healthcare that is not necessary is coming out of wages, it's coming out of business growth, it's coming out of all of the benefits that people need to be healthy. So as you mentioned, we have 40 members. We've been around for about 35 years working on cost, quality, and access. And our challenges have only gotten worse. What we are collectively doing is trying to tackle these challenges of affordability. Remember, private employers are paying all of the profits for the US healthcare system. And so most employers purchase healthcare through health plans, through these intermediaries like United or Aetna or Cigna. But what's happened in the last 10 years or so is they have become so consolidated vertically and otherwise that it is just getting harder and harder to get the transparent information and to get the, frankly, the support and the responsiveness to take on the challenges of affordability. And now this year, we're starting to see double-digit increases. Some of them are up to 25%. We think this is the beginning of a new 10-year trend. Hopefully not, but all signs point to just accelerated growth. And despite how much our members pay for healthcare, despite how much purchasing they do on behalf of so many Americans, they still cannot get the data they need to hold their partners accountable, either at the plan level, at the PBM level, or at the provider level. So there is a new push from employers. And I have to say, I've been at this personally for about 20 years, so there's not much that is new, but the urgency to access this data, it has only increased, in part because of the policy environment we are in, and in part because of the affordability crisis. The policy shift that I think is going to potentially be a bit of a game changer here is the Consolidated Appropriations Act, which, as many of you probably know, basically puts additional fiduciary obligations on self-insured employers. There were some changes to ERISA that make them personally, some of the executives, accountable for ensuring they are only paying fair prices. And as I indicated before, there has been a traditional reliance on consultants and health plans and PBMs to do that work. But as is evident by the cost trajectory, that has not been working to the benefit of self-insured employers, public purchasers, or the beneficiaries of those programs. So now our members have prioritized partnering with new partners who are unconflicted and are transparent, and they are really having to change their entire purchasing strategy, which assumes and requires access to transparent data. I think when you think about purchasers, they have a supply chain practice for everything in their business. So if you think of Boeing, they know down to the penny what they pay for tires or different parts to their airplanes, and they manage those costs exceedingly well. And yet there is still a challenge getting the information needed to purchase healthcare that can be that is clearly high value. And now that these companies are being held to a legal standard of being experts themselves, it is changing the demand for data. And this is my last slide, and I'll be really clear. But the thing that I want to point out mostly is that ERISA fiduciary responsibilities require employers to pay only reasonable expenses. We know from decades of research and data that 30% of healthcare spending is wasteful. It does not improve health. It does not improve value. And so to be able to ensure that they are only paying fair cost for high quality services, that requires transparency. It requires price information. It requires visibility into negotiated rates. It requires visibility into relative quality. All of those pieces of information that will enable effective purchasing have not been available to purchasers adequately. So this is a new environment. It will force new relationships with traditional partners and vendors. We are seeing some of our members using the newly available CAA data, like going to regional hospital websites and looking at what an average cost should be, and then actually comparing it to their claims experience and realizing they are overpaying dramatically and then challenging that. That was not possible before some of the new transparency regulations. So this is the beginning of a new era. The healthcare cost boards in states can contribute to this. They can make the data more easily available. They can start to rationalize spending and set benchmarks on what is a fair cost for a healthcare service. These are absolutely necessary steps that, again, I believe states have to take because the industry has not made it possible to do this. So as we get more and more clarity, transparency, visibility from these state entities, that will inform effective purchasing by private and public purchasers. So I think these new data initiatives are, as I said, necessary but insufficient. I think transparency will be a critical tool for redesigning the healthcare system to one that actually provides value and meets the healthcare and affordability needs of people. One last thought is we simply don't have 10 years. We look at these long-term strategies of, in 5 years, we will hold a hospital accountable, and maybe we will come up with a new payment model. We have people every day right now foregoing care. We hear at every OCA meeting from people who are having to drive 2 hours to get an affordable visit, or even be able to access a primary care physician. We cannot keep waiting and talking and examining the data. We have to act. So with any luck, these cost boards will enable that action in a way that is most effective. So we are fully supportive of these entities, of the work, of the focus on actual affordability, not just costs. We need to think about this, how it affects purchasers and the people trying to use the system. So we are eager for this to be as impactful as possible, and we'll continue to use the data as it becomes available.
Thank you so much. Let's bring on Vishal.
Thank you, Kevin. So I'll be going over the key components of OCA and providing an implementation update. So I do want to set a little bit of context. OCA is housed within the California Department of Healthcare Access and Information. This is the mission statement, with affordability being a new pillar being added to HCI. So these are the program areas of HCI, the overall department. I do only want to call out one program area, which is integral to OCA's work, is that HCI also manages several data assets, including the Healthcare Payments Data Program, or California's all-payer claims database. So this goes hand in hand with the work that OCA is going to be doing on measuring total healthcare spending and enforcing cost targets. So I'll provide a little bit of context on the value proposition for an office. The other panelists are also providing several support for this, so I won't belabor the point, but just want to provide a few key facts. Next slide. So this slide shows the growth in per capita healthcare spending as a percent of median income over the last 30 years. And you can see here that for California, the share of income being spent on healthcare was about a little less than 8% in 1991, and has since grown to about 14% in 2020. And this just shows the per capita health spending in California over the same 30-year period, growing to $10,300 per capita in 2020, representing about a 5% average growth rate, annual growth rate, that is. Thank you. So I'll be going over the key program areas of OCA. There's the first one is slowing spending growth. The second is promoting high value system performance. And then the third program area is assessing market consolidation. So in terms of slowing healthcare spending growth, we'll be collecting data on total healthcare expenditures. We'll be developing a spending target methodology and setting spending targets. Initially, there's a statewide target for calendar year 2025. And then in the future, we could set sector-specific targets, which is essentially having a more tailored approach rather than having a one-size-fits-all target at the statewide level. We could set different targets for different geographic regions or types of entities. So the first target will be for calendar year 2025, and it will be a reporting year only, and the targets will be enforced beginning with calendar year 2026. We do have a progressive enforcement approach where we will find out what happened, and if compel public testimony at a board meeting, we could require performance improvement plans, and then as a last resort, we can administer financial penalties. So we are unique in our program as not just being about transparency, but also about enforcing spending targets. You know, it's also important for us to not to just focus on slowing spending growth, but also promoting high value system performance. So we have several activities related to measuring quality alongside costs, and then reporting on alternative payment model adoption, as well as primary care and behavioral health investments. We also have a distinct program on assessing market consolidation, where we will look at transactions that are currently not being looked at, as market consolidation has been linked to higher prices. And we'll be filling in gaps by receiving notices for transactions currently not being looked at by regulators, and then conducting a review, a cost and market impact review, to assess whether the transaction is in the public interest, and work with other regulators to assess market consolidation as appropriate. So I'll be going over some updates on the spending target. We're excited to be at a stage where we're having discussions with our board about a proposed spending target. So before I launch into the specifics of some of the considerations, I do want to just remind everyone about kind of what we're measuring. We're going to be measuring total medical expense, which is claims payments, non-claims-based payments, which in California capitation is a big part of, and then consumer cost sharing obligations. And then we add admin costs and profits on the health plan side, and then we get to a total measure for THCE or total healthcare expenditures. And that's going to be what we're using to assess against the spending target. So these are just examples of claims-based categories, as many NADO participants are familiar with. Similarly, here's a list of non-claims-based payments. So you may be wondering who's subject to the spending targets. So it's payers, providers, and fully integrated delivery systems. So OCA does have a comprehensive approach and the types of entities it's going to be looking at. So, we're going to be collecting a lot of data. We're going to be able to report it at different levels, from more aggregate levels like statewide or regional levels to market. And then I do want to call out columns 4 and 5 here, where we could get into payer-specific and provider-specific reporting. And then at the most granular level, we'll be able to look at service categories, such as retail pharmacy or inpatient. So as I mentioned, we're excited to be at this stage of developing California's spending target in close coordination with our board, who is the ultimate decision maker on the spending target. We are considering various economic indicators and population-based indicators to tie the target value to one of them. The next slide goes over the types of indicators we're looking at. The first 5 are economic indicators. The last one is a population-based indicator. And I do want to say that our board has, indicated some preference for a consumer-centric measure that's a little easier for consumers to understand, such as median household income or median wages. So this is just a timeline slide, and I know there's kind of a lag in terms of, as many of you know, about collecting data, validating it, and then reporting it out. So this just illustrates, our first target that is enforceable is 2026. We are going to be collecting 2 years of data to measure that change, from 25 to 2026. We have to wait for claims run out, so that we won't be getting those 2 years of data until sometime in September of 2027, and then we have to analyze and report it out in an annual report. So enforcement won't be happening until sometime in 2028 for that first enforceable target that is for calendar year 2026. So I know I put out a lot of information. I do want to also direct everyone to OCA's website, where we have public materials for our board. And also our monthly meetings are open to the public, and want to turn it over to the next presenter on this panel for the next portion. Thank you.
Thank you, Vishal, and thank you to NADO for the opportunity to present today here on this panel. As mentioned at the top, my name is Lauren Peters, and I'm the Executive Director of the Center for Health Information and Analysis, otherwise known as CHIA. And I'll be speaking to the Massachusetts experience and how we're continuing to evolve our program as based on lessons learned and experiences in other states. So just a brief history. In 2012, Massachusetts passed comprehensive cost containment legislation that was really aimed at reining in healthcare spending to bring it more in line with the state's economic growth. The law created 2 agencies, the Health Policy Commission and CHIA, and the agencies are really charged with monitoring and enforcing the state's cost growth benchmark. At a high level, and as depicted here, our process, just to give you a sense of, for those less familiar of the annual cycle, and how we're implementing this, is our process kicks off with the setting of the healthcare cost growth benchmark, typically done in the spring. CHIA then collects data from payers on total medical expense for payers, both their members at both a network-wide and by primary care provider group. And that data is collected, we collect both health status adjusted as well as unadjusted TME. CHIA then analyzes the data and confidentially refers any payers or provider group whose increases in HSA TME exceeds the benchmark. HPC then conducts further confidential review of referred entities, and the board makes a decision to require a performance improvement plan, or a PIP, in some cases. Those entities, if they're non-compliant with the process and implementation of the PIP, can be subject to a modest penalty of $500,000. In addition, each year CHIA reports out the overall market's performance against the benchmark through the calculation of the total healthcare expenditures, often referred to as THCE, and also includes sort of a deep dive analysis of other spending trends through CHIA's annual report. In parallel, HPC holds its annual cost trends hearings based on the findings in CHIA's annual report. And the hearings are really a public forum where industry leaders testify under oath about the reported healthcare cost growth and underlying factors. This informs and sets the stage for the next annual cycle. So successes to date. As we see here on the slide, we have been successful following the implementation of Chapter 224 in 2012. We have been successful in slowing healthcare cost growth in Massachusetts and have been at below national growth rates, acknowledging that there is an exception in 2021, which I'll speak to later on in my presentation. Other successes, I would say, is really around this shared accountability framework. The public process, particularly the HPC's cost trends hearings, brings entities across the healthcare system to the table in an unprecedented way. The bully pulpit model provides a valuable opportunity for healthcare entities across the market to provide testimony and respond to questions on their efforts to constrain spending in a public forum. The benchmark is also used and cited as a tool in contract negotiations between payers and providers. And while there's varying perspectives on how exactly the benchmark should be used, whether it's a blunt cap on prices versus just a target, we do know that the benchmark has been invoked regularly through payer-provider contract negotiations. And then finally, CHIA's data collection and analysis processes allows us to really identify specific cost drivers in a more granular way. And that enables and informs more targeted policy interventions. For example, year-over-year, pharmacy spending increases have been well above the benchmark. We're able to break it out looking at net and gross of rebates. And this has spurred various proposals in the legislature to address pharmacy spending, really directing those interventions at the root cause. So those are some examples of what I would call the successes of our program. But the challenges to date, there are a number of areas that sort of warrant further review and refinement. Some of these include, with respect to data, to date, CHIA relies on aggregate payer data to calculate the total medical expenses and total healthcare expenditures at the statewide level. However, the rolled up nature of this data certainly does have its limitations. We also have data lag, I think as mentioned, to allow time for claims runout and to enable us to QC the data. The spending data in CHIA's annual reports refers to more than a year prior, which is a challenge given the rapidly evolving healthcare landscape. The scope of the benchmark and accountability framework also has limitations. It doesn't capture all market participants. Referrals are limited to health plans and managing physician groups and does not include pharmaceutical manufacturers, PBMs, and other market participants. In addition, the requirement that referrals to the HPC for a potential performance improvement plan needs to be based on health status adjusted TME, otherwise referred to as HSA TME. And that is limiting because risk adjustment methodologies does not always accurately capture differences in populations or provide the whole story. With respect to enforcement, there have been numerous questions raised as to whether the law affords the Health Policy Commission with enough teeth, if you will, to enforce and really hold entities accountable that are exceeding the benchmark. In part, this is due to the benchmark is a target and not a requirement, and there's not a hard and fast penalty for entities that do go above the benchmark. Really, there's been only one performance improvement plan imposed to date, and there are limitations to the PIP process itself, including a maximum cap of $500,000 on fines for entities' non-compliance. And for some providers and payers, this is small dollars in the scheme of things, particularly for those exceeding the benchmark. And then finally, there are inherent challenges in applying a static blunt benchmark to an evolving and dynamic industry, and one where entities had varying starting points when the law was first put into place back in 2012. Two examples of where this has been a challenge. challenges with a uniform cost growth benchmark applied to entities with varying starting points, as mentioned, has merely baked in price variation among providers in our system, reinforcing the haves and have-nots, and doesn't account for the fact that some providers who have historically been underpaid may benefit from over benchmark increases. A static benchmark also doesn't account for intervening factors or dynamics, most notably a global pandemic, for one. The significant spending growth well over benchmark that we saw in 2021 that I alluded to earlier didn't account for the suppressed utilization we saw in 2020. Accordingly, we had to make modifications in our 2022 annual report, specifically to the THCE, how we reported the THCE and other relevant metrics, to analyze them on an annualized basis over a 3-year period between 2019 to 2021 to provide a more contextualized picture of our healthcare landscape, because showing just the year over year from 2020 to 2021 would not have shown the whole picture. So as we think about the maturation of our program, there are a number of opportunities for refinement to address some of the challenges that I mentioned earlier. With respect to data, she is starting to use and incorporate more data sources in the annual report in order to complement the aggregate payer data and provide that more comprehensive analysis of the performance of the healthcare system. So including things like case mix, quality data, and the like. We're also continuing to work with data submitters to streamline reporting and identify ways to obtain the most recently data available. With respect to scope, I think that there's a number of opportunities to expand the framework, both with respect to entities covered and sort of the domains and metrics that we're tracking and measuring. So with respect to entities covered, I think one area that we're looking to expand is bringing in pharmaceutical manufacturers, PBMs, individual hospitals, because we know that these entities are big contributors to our healthcare spending and our cost growth year over year. With respect to expanding the scope of the annual report, we're looking to track and benchmark measures of affordability, health equity, to more accurately reflect the experience of Massachusetts residents. Because as a system, we may be under the cost growth benchmark, but that is often not the experience of individual purchasers and consumers or subpopulations within. So taking a more nuanced, tailored approach. With respect to enforcement, there are a number of recommendations out there to strengthen the PIP process. For example, one of them is to really apply a tougher escalating financial penalty for above benchmark spending or non-compliance. And this is sort of consistent with our colleagues over in California. So these are all areas that it's helpful to sort of learn from our counterparts in other states based on their experience. Additionally, with respect to enforcement, updating how referrals are made. So using non-risk adjusted total medical spending to make referrals to ensure that real dollar spending increases are not masked by medical coding efforts that reduce growth rates and health status adjusted measures. And finally, it's critical we continue to evolve our approach to the benchmark in terms of how we monitor, apply, and enforce the benchmark. What this means is incorporating and accounting for new factors. An example is CHIA began collecting data on temporary staffing costs to better understand the financial impact on Massachusetts hospitals and health systems. And this, in return, allows us to inform a more nuanced approach to the benchmark and policies around workforce and temporary staffing, which we all know has been a big cost driver for providers. And another example of how we're continuing to evolve is including additional metrics when evaluating entities against the benchmark and how it's applied. So as noted earlier, healthcare entities vary considerably in their baseline spending levels, the pricing levels, and populations served. And therefore, spending growth may be more or less concerning for a given entity based on these contextual factors. And those are things that should certainly be incorporated into the process so that we are not using such a blunt instrument.
Lauren, thank you so much. And Elizabeth and Vishal, thank you again for serving as panelists here. Charles and Norm and everyone else in the audience, please, in the chat, insert your questions and answers, and we'll be able to hopefully get you a couple of live responses in this session, and maybe even follow up offline for those we don't get to. So thank you for your introductory presentations, and now let's get to a few questions. Yeah, so change my shirt just like that. It really great presentations, Elizabeth and Vishal, and Elizabeth, I actually want to come back to your presentation and a question for you. So now we have about 10 or 11 states engaged in cost growth benchmarking program development. That leaves 39, 40 states that don't have a program in place or in development. Like, what advice would you have for policymakers and industry leaders on how to form an effective multi-stakeholder coalition to advocate for this type of system change, as you did so well in California?
Well, first, I would say we need to have national action. It's wonderful that these states are playing these leadership roles, but most jumbo employers are national. And at the very least, if they don't have a national solution, the states ideally would align and do something consistent. So maybe we have similar benchmarks or similar data sets, but getting to that sort of national consistency will enable the largest purchasers to effectively use the data. I would say it's a coalition of the willing, and frankly, there are so many willing partners ready to tackle affordability. We've got consumers, unions, purchasers, private and public, a lot of policymakers. So I really just think it's showing the opportunity, what can be done. I don't think you could talk to someone and say, how do you think the healthcare system is doing? And they say, oh, it's great. It's well priced. It's easy to use. I mean, it is a pretty wide pool of people who would be happy to contribute. So we need an organizing maybe entity or program, but I think there is a lot of readiness out there to tackle this.
Yeah, and you do have that commonality. The groups you listed, like you're bringing the employer, community, consumers, labor. These are all demand, folks who demand healthcare. They're purchasers of healthcare, and pulling together that coalition in California. Did that come together just naturally, or like, is there anything that other states should think about, like if they are wanting to advocate for something like this, but not quite sure how to approach it?
I think we were sort of naturally aligned, but it does take some organizing work. Again, some just consensus building, some sort of clear partnership priorities, but that's doable. I mean, I ran a national organization of regional coalitions, and there's a lot of skilled leaders at the regional level who I think share this urgency. So again, just showing what's possible, showing what should be expected, and some of the key effective levers, and then it's a matter of just bringing folks to the table to do what needs to be done.
Yeah. And speaking of bringing folks to the table and doing what needs to be done, Vishal, I mean, you have a tremendous job ahead of you that you're already, I think, I don't know if it's like waist deep or neck deep in to help move it forward. And setting up a cost growth benchmarking program is an extensive operational endeavor. But as Elizabeth was mentioning too, it's also, there's a really big necessary element of culture change in the healthcare system that's required as well. Like actually making entities understand that they are now going to be accountable for healthcare spending for a population over time is something that's kind of, I mean, it's strange, but it's like, it's new. How have you thought about both a proceeding on the operational side, but also this bigger culture change piece that often goes under reported? Oh, I can't hear you, unfortunately.
I think is this better? Oh, great. Okay. So that's a really good question. OCA has a role in terms of setting the target, collecting data, and enforcing the targets. But it's the plans and providers, the healthcare entities that we regulate that actually have to do something. So we know there's opportunities there. A California Healthcare Foundation survey or a study, examined a range of factors that contribute to healthcare spending, including overtreatment and administrative complexity. So, based on this research, it's estimated that California could save between 58 and 73 billion per year by eliminating waste and improving efficiency. So we know that the opportunity is there. And we're at an exciting stage with OCA in terms of in the coming months, we'll be discussing a proposed spending target, and the board will act on and decide what the target is. But OCA also wants to engage the healthcare entities that are regulated, and we've been speaking to them already in terms of what are the innovative practices out there, what are the success stories of, because there are healthcare entities that are managing cost and improving quality. We want to showcase that. So if we do expect to receive pushback in terms of whether the targets could be achieved, so we want to point to examples where healthcare entities are doing great things on cost and quality. So we're calling this cost reducing strategies work, and we'll be showcasing that at future board meetings.
Could I just pile on there a little bit?
Yeah, go for it.
As a board member, these conversations at the board are with the public and any interested parties. And I think it's a really important opportunity to center actually the people paying for care. We have for years, decades, measured the cost of care and the inputs of the cost of care. But we need to be having a conversation about what is affordable. That was, I think, an important orientation. And I inviting the members of the public to come say how they are experiencing the healthcare system is really profound, because people are really struggling and suffering. And so just really remembering why we're doing this, I think, is part of that culture change. And then to Vishal's point, there are win-wins here. We have done projects with, small independent practices in California. And when they are given the tools like data and maybe a social worker or a community health worker as part of their team, they can make really impressive changes that are both better for quality and outcomes and also for affordability. So helping with that roadmap to where this can be more of a win-win.
Thank you, Board Member Mitchell. We're excited to, in addition to the cost reducing strategies, kind of the healthcare entities, we also want to uplift the consumer voice as well. So we do have some ideas for that. And if you're listening to our board meetings, stay tuned for more elevation of the consumer voice.
Yeah, and I love both of your thoughts on like a little bit of an ad hoc question here. Cost growth benchmarking programs are well designed to track overall healthcare spending trends over time, but you're also raising a really important point of like making sure that within that spending, we're really tracking like who's bearing the burden of those costs and how that burden is changing over time. How are you thinking about it as like the California program starts to form? Like, what is the consumer, Vishal, component look like?
So we expect to have, some of these conversations we have at our board meeting are very wonky, and we do want to make it more accessible for consumers and bring in that kind of consumer voice to our meetings. So, the public has been very engaged and have been making public comment, but we also want to put our board members in venues where they could listen to consumers, because not everyone has time to come, dial into a board meeting in the middle of the day. So, we do expect to continue to engage consumers and, potentially holding board meetings, not just in Sacramento, but other parts of the state.
Elizabeth, any thoughts?
Again, I think Vishal mentioned that we're looking at indicators like median income, because it is really about what people can afford, not just the cost inputs for the providers. So again, we've got to just rethink how we measure affordability, because affordability and costs are simply different. And I applaud OCA and HCI for really enabling that rethinking of our methodology. But again, this is new. We sort of, look under the light post. So we have claims data, so let's measure claims. We've got to think more broadly about the needed data and the needed indicators to really measure affordability.
Really interesting responses. And I see a question in the chat, of the states that are implementing or thinking about implementing state cost growth benchmarking programs. A lot of the ones to date are more politically lean as blue or Democratic. And is there any expansion expected in swing states or red states? And to answer that, I'll actually point out 2 states that have programs in development that might not look the same as what's proposed and being developed in California, or what's matured in Massachusetts, which Lauren shared in her presentation. Maine, I think 2 years ago, established by statute an Office of Healthcare Affordability. This year, they're moving from a staff of 1, now that they have an executive director in place, to a staff of 3, and they're starting to make progress on setting a target. I'll also give a call out to Minnesota, which is not necessarily a red state, depending upon the election, may not be a swing state, but they're setting up a program. And I'll also mention Utah. Utah is taking a really innovative approach where they have a voluntary program that's starting to be developed, a public-private partnership sponsored by the One Utah Health Collaborative, where they are bringing industry stakeholders to the table. Because Elizabeth, as you mentioned earlier, I mean, this is no one in the healthcare system thinks the healthcare system is working well. No one thinks the cost growth that we're seeing this year, double digit or more, high premium increases, is sustainable continuously. And so they disagree on who's to blame for that. But it is an encouraging nascent model of even private stakeholders getting together and thinking about how they can hold one another accountable to a potential voluntary benchmark. So there is increasing demand for these programs across the country and across states. And I would not be surprised if they started kind of following the same trajectory as APCDs, which might have started off in more blue states as we're considering them. And again, the last 4 states that have an APCD are all red. But Elizabeth, anything you'd want to mention there?
Yeah, I mean, I cannot imagine healthcare affordability being partisan. I mean, we're talking about families, we're talking about businesses. I mean, reducing healthcare spending is an economic growth strategy for businesses. You're reducing their burdens, you're increasing wages, you're reinvesting in public infrastructure. So I just don't see that as a partisan issue. I certainly understand that some industry is going to be uncomfortable with these new expectations. I happen to be somewhat wary of the voluntary only approach, because there is nothing stopping industry from starting today. They could voluntarily lower their rates next week. So I think we need to truly ensure that those are efforts that lead to actual changes in affordability.
Yeah. Vishal, anything to add on that front?
Yeah, I would say it's not a blue or red state issue. This, the first adopters maybe tend to be more blue states, but compared to kind of other strategies like rate regulation that are kind of more controversial, I think this is kind of a more middle of the ground solution in terms of setting benchmarks, increasing transparency, and then getting at the drivers. So I would expect to see more states in the future be open to these types of programs.
Yeah.
Can I just add one other catalyst?
Yeah, of course.
You know, those of us who live in the self-insured world understand the importance of the Consolidated Appropriations Act that is going into effect this year, that holds self-insured employers and other purchasers accountable for how much they are spending. They have to be paying fair rates. And to pay fair rates, they have to actually have access to them. They have to have data and visibility into pricing and quality. That is going to have a cascade effect on necessitating transparent data, because they won't be able to fulfill their fiduciary duties without transparency, without understanding pricing, relative pricing, and otherwise. So I think you're going to see just increased pressure from the purchaser side to actually have usable information to ensure they're paying fair prices.
Yeah, and I think that kind of the concept of price. And hi, Lauren. I know you've been actually doing the duty of the cost trends hearings today, so really nice to see you. I have a question for Vishal, and then I'll go to Lauren, and then we'll close up, and maybe with a question if a chance. So Vishal, I mean, cost growth benchmarking programs provide an aggregate state look at how healthcare spending in a state is growing. It attributes that to certain managing providers by different methods in different states, but it's a cost measure. One thing that many states have done, including Massachusetts, has done really well, is being able to pair the cost growth benchmarking data with their APCD data and some other new data that might be coming online. Price transparency comes to mind, to dig deeper into issues. Like, how are you thinking building California of using these data like resources in tandem? And then Lauren, I'd love any comments you have about how Massachusetts has leveraged that pairing.
Yeah, the HPD, or is the Healthcare Payments Data Program in California, which is our APCD, is going to be a critical tool to do that deeper dive. The THCE data that we're going to collect is going to be aggregate, and it's going to tell you which categories are growing, but it's not going to tell you why. So we're going to rely on our HPD to do that deep dive. And it's interesting. We have that these two programs are pretty new in California, so it's good that we have that tool. And then, other data that's coming out under the federal transparency rule about hospital rates. There's other studies like the RAND transparency study on hospital prices. So yeah, we're excited to kind of, we have these tools at our disposal to look at the drivers. And then ultimately that needs to lead to policy action in terms of OCA making recommendations, or policymakers, potentially taking action for any kind of anything that's actionable in terms of what we could do on prices or other types of drivers of cost.
Terrific. So Lauren, like, how has Massachusetts employed like the cost growth benchmarking program, APCD data, other data that might be available to it through CHIA to lead to action, like the action you were hearing today?
Sure. Thank you. And apologies for being late here. As Kevin mentioned, I'm just spent about the last 8 hours in our annual cost trends hearing. So very timely panel. And I think to that point, one of the sort of significant, if not most pressing themes coming out of today's hearings was around affordability and equity. And there was, I think it's safe to say, a mandate coming out of the hearing today that we need to sort of embed or install an affordability benchmark within the broader spending benchmark that we've set for ourselves. And I think in order to do that, we at CHIA have already been thinking about sort of merging different data sets, not only our aggregate payer data, which is what we use to measure the THC, the total healthcare expenditures, but merging that with case mix utilization data to say, okay, for in terms of affordability, there are disparate outcomes in terms of if you can't afford care at the right setting. We are seeing higher utilization rates for Black and Brown populations of the emergency department, of inpatient system. And without that case mix utilization data, we can't then layer to get that deeper dive look at affordability. Similarly, we're using some of our survey data to look at how affordability, specifically premium costs
out-of-pocket spending costs, how that is leading to sort of foregone care or certain care decisions that have an adverse outcome. But again, that is an example of us using that high-level aggregate spending data and then layering it on with some of our additional survey data, case mix data, to provide that more comprehensive context and framework.
Excellent. Elizabeth, I'll give you the last word, like 30 seconds. Like, why should states invest in healthcare cost growth benchmarking programs?
Well, I think it is a key tool to achieve affordability, which is the point that I think we're all talking about. I think states have a unique capability to sort of bring the data together, require some change. But I also think there's an opportunity to partner with purchasers to use the data in contracting, in network design. I think we need to expand our focus and think about all the levers available, because we are representing those who pay for and experience care. So I think there is a mandate, and I think states are well positioned to lead.
Elizabeth, Vishal, Lauren, thank you so much for participating in this panel. And Norm, over to you to close us up. Oh, I can't hear you, Norm. You're on mute. So
Thank
close.
You.
Like
there
this
we
close.
go. I'm an expert at that. It's a fabulous panel. Thank you, all of you, for your comments, your remarks. It got me really thinking about benchmarking, how we can apply that more broadly. 2 quick announcements for everyone. First, we want to announce the winner of the Day 2 drawing. Those of you who've been playing the token hunt game, here it is. The winner of a $50 Amazon gift card is Hannah Murphy. So congratulations, Hannah. We saw Hannah earlier today, actually, in one of our presentations. And then tomorrow at 11:30, we have the virtual coffee shops. They'll all be open. I had a great time there today meeting a few people, and hope you got to meet some people too. But the sessions start tomorrow at noon Eastern with our federal officials panel. We've got some fabulous federal health data officials. You'll want to make sure that you attend that to hear what's latest on their minds. So thank you, everyone. We will see you bright and early tomorrow, especially if you live in Hawaii. I know it'll be early for you, and we appreciate you getting up early. So thank you all, and we'll see you tomorrow.